Good morning, everyone. It is with great pleasure today. I would like to invite you all to the second webinar of the IFS UK Forum, and it's titled Updates in Reproductive Medicine. My name is Dr. Harish Bandari. I'm a consultant gynecologist and a reproductive medicine specialist in Leeds. And I'm also one of the executive committee members in the British Fertility Society. And I'm the Joint Secretary of IFS UK Forum. So I'll be co-chairing today's session with Dr. Raj Mathur, who is a consultant gynecologist and a reproductive medicine subspecialist in Manchester. He's the immediate past chair of the British Fertility Society and is also the secretary of the IFS UK Forum. We also have Dr. Uma Gordon. She's a consultant gynecologist and a subspecialist in reproductive medicine, and Uma practices in Bristol. And she's the treasurer of the IFS UK Forum. And we are joined by Dr. Jayant Mehta, who is our patron at the IFS UK Forum.
Hi.
As most of you already know, that the IFS UK Forum was launched in 2024. And one of the aims of the forum was to promote good practice and shared learning in the field of reproductive medicine and surgery between the two countries. There was a great response to our first webinar, which was titled Back to Basics, and that was in November 2024. And I'm pleased to note that today you have preferred to attend this webinar over watching India versus Pakistan cricket, which is happening at the moment. We have three great talks this morning, and they'll be for 20 minutes each. And immediately after the talk, we'll have 10 minutes for any questions. So please post any questions you have in the chat box, and we'll pick them up. Dr. Efia Yasmin is our first speaker. A little bit of introduction about Efia, although most of us know about Dr. Yasmin. She's a consultant gynecologist, and she's the lead for gynecology in University College London Hospital. She's a subspecialist in reproductive medicine and surgery, and her practice encompasses, most of the aspects of reproductive medicine, including pediatric adolescent gynecology, complex congenital gynecology, infertility, and fertility preservation. She has various executive committee roles. She is in the British Society of Pediatric and Adolescent Gynecology as the executive committee member. She's the chair of the Fertility Preservation UK Special Interest Group of the British Fertility Society. She's the executive committee member of the ASHRAE certification of reproductive endoscopic surgeons, and she's also UK representative of ASHRAE. Efia has written several book chapters and published her work in peer-reviewed journals. And today, Efia would be giving us an important talk in this webinar. Over to you, Efia.
Thank you so much, Harish and Raj and the rest of the IFS team for giving me this opportunity. I'm delighted to be here. And I'm just going to share the screen, and hopefully, I'm not very familiar with Zoom, I have to say, so it takes me a little bit of time. Let me go to screens. Can people see my screen?
Yes, Efia, I can see.
Great. Okay, thank you very much. Thank you. So differences in the development of Mullerian structures is not commonly encountered. So sometimes, when we do encounter them, it can throw some kind of diagnostic or even management conundrums. And I thought I would share about nearly like the 20 years of experience in this field. And what I would also like to point out is in most of the cases, these are actually not anomalies because we would use the term anomaly for those kind of differentiations that will impact on function. And many of them will not. However, there are some unique kind of features that we need to work out and figure out in order to correlate symptoms and decide on which management options we will adopt. So the remit of the talk today, because it is a vast topic, I will limit myself to some fertility implications and mainly to the menstrual disturbances, any pelvic pain, what it means to their sexual health. And these are sort of the issues that you will encounter with the different types of Mullerian differences. So one is, will we see any changes in puberty, such as, in delayed menarche? What does it mean to their fertility and future fertility health? We have to exclude premature ovarian insufficiency. I'll come to that. And we have to also look at, the effect of these conditions on pelvic pain, and this could be in the form of endometriosis risk or adenomyosis risk. So before we go on to the actual anomalies, I would just like to point out or remind ourselves of the Wolffian and mesonephric duct, or the Mullerian and paramesonephric duct structures. Why do I mention this? Because both of these structures coexist and they develop around the same time, around 5 or 6 weeks gestation, and then they will differentiate if there is the absence of AMH, anti-Mullerian hormone, then they will develop into the uterine structures. But any interruptions to their union or to their canalization and differentiation can lead to various differences. Okay, so and because the Wolffian duct structures will contribute to the renal structure, to the renal tract, and therefore any Mullerian differences or anomalies may be associated with renal tract anomalies. So if we detect Mullerian, we should be looking at renal structures as well. I'm just going to make sure I've got the right. Sorry, I think it is this one. Okay. That also reminds us that in different stages of puberty, or especially in prepubertal stage, we will often not see the uterus very well. So this, just illustrates how thin the uterus might be. And under the influence of estrogen, there will be the development of the uterine corpus, the cervix. And this is the reason why we absolutely must make sure that the gonadotropins and estrogen are normal before we make any diagnosis of absence or differences of Mullerian structures. So when we come to its incidence in different situations, the incidence or what we will encounter will vary. In unselected population, so in general population, this is expected to be less than 5%, slightly higher in infertility, more in miscarriage. And if we combine infertility and miscarriage population, this is where we will see the highest incidence of Mullerian anomalies. So let's come to the first anomaly, which is Mullerian agenesis, or the MRKH, Rokitansky-Kuster-Hauser syndrome, or MRKH variants. Now, although this seems simplistic and to say that any absence of the uterus completely would mean a diagnosis of MRKH. There can be some differences and nuances within this condition. And one of them is it may be the absence of the cervix, but the corpus may be present. There are often two rudimentary buds with or without differentiation of the endometrial structures within the uterine buds. And sometimes it can be so subtle as to only have part of the cervix missing. Now, it's so important to kind of distinguish this because in certain conditions, such as complete absence, there is no other opportunity for conception other than surrogacy or a uterine transplant. Whereas when it comes to just a section of cervix missing, then the anastomosis, a cervical vaginal anastomosis, may be an option. So definitely the impact of these conditions naturally will be infertility. And there could be hematometra, adenomyosis, or even endometriosis when there is endometrial differentiation, which will lead to the collection of menstrual blood. And this will have nowhere to go, and this will increase these risks and will present with pelvic pain. And so when we have, say, a situation where there is the rudimentary horns with differentiation, we may need to remove them. Now, the ovaries are usually unaffected. However, the ovaries are often placed quite high in the pelvis, and this is very important to know when we are performing egg collection. So these are the two MRI pictures here. There's a complete absence of the uterus, and we can see the two ovaries on either side. And here we are. It's quite clearly seen where you have the rudimentary uterine horns, two on either side, with clear differentiation in the endometrium. And as I said before, we do not diagnose MRKH unless we have got evidence that they have gone through puberty and their endocrine function is normal. And indeed, we get a smattering of referrals as MRKH when indeed they are either POI or hypogonadotropic hypogonadism. And this is an example, like a case series of different conditions here, where after the initiation of estrogen, the uterus started to develop and therefore was not MRKH. Let's come to unicornuate uterus. Now, unicornuate uterus, as you know, is characterized by having one horn and there's the absence of the other horn. Now, these conditions do not make someone infertile because the fallopian tube and the ovarian function will be normal. There will be conception within the unicornuate uterus, but with a higher risk of preterm labor and breech presentation. However, whenever we see a unicornuate uterus, we must always look for the other horn because either they may be completely absent or hardly visible, or it may be present, again, without differentiation or with differentiation. And it is important to distinguish this because if there is an endometrial cavity in a non-communicating uterine horn, there is a risk of an ectopic pregnancy in that horn. So here, either with ultrasound scan or MRI, here we can see clearly a unicornuate uterus, and here you can see the other rudimentary horn. So let's come to uterus diadelphys. So this is where both the Mullerian ducts have developed individually, and usually there will be no other issues. Sometimes there is a complete duplication, such as having a longitudinal septum, and sometimes this longitudinal septum may be attached to the lateral vaginal wall, causing an obstruction of one side, which is called obstructed hemivagina. Now, if there is no obstruction, there will be no implications on fertility for these individuals. But when the pregnancy occurs, it will occur in one of the horns, and this will increase the risk of malpresentation, preterm labor. So basically, they will behave like pregnancy in a unicornuate uterus. Other implications for health, when we have a duplicated system, is to remember to take cervical smear from both services. And if a septum is present alongside, this can lead to difficulty with sexual intercourse or inability to wear tampons. And if there is obstruction, this obstruction needs to be removed. Otherwise, it will increase the risk of naturally cause pain and increase risk of adenomyosis and endometriosis. Here we have some images of uterine diadelphys. So here you can see that both endometrial cavities are the same, and therefore there is no obstruction. And this is the telltale sign, and we need to differentiate this. So uterine diadelphys may sometimes be confused with a bicornuate uterus or a septum, but here we can easily see the indentation, and it's completely here, right down to the cervix, okay, the division. And therefore, this is not a septum, and it is not a bicornuate uterus, which will usually end around here. Okay, so there's a complete duplication. Sometimes these two uteruses may be completely separate, so you will see a complete gap between the two, but sometimes they may be fused together. So this, on the other hand, is a septum, and we look at how muscular the septum is and how fibrous the septum is. And now this differentiation is also important again, because if you're going to resect the endometrium, the uterine septum, then we need to know what kind of resection we will need to do and how much to go for, because we wouldn't be disrupting the myometrium so much. So here again is an example of the uterine septum, which is quite muscular, broad, and this is after its removal. So uterine, just to say, however, I'm not going to go into details of how the surgeries are done, but uterine septum resection is not performed or not advised that it would be performed without an indication, and that indication being a history of infertility or miscarriage, because there will be pregnancies in the presence of a uterine septum. And the jury is still out. There is no clear indication actually of where it needs to be done. The other issue that may be associated with a uterine septum is if it implants onto the septum, the risk of abruption will be higher. Now, let me spend a little bit of time on obstructed hemivagina, because these other conditions where there is, say, complete absence of the uterus or a block may be more easily diagnosed because the presentation is quite kind of remarkable. But in obstructed hemivagina, these patients actually have periods, so they will have normal menarche, but it is from the other uterus that there will be no outlet for the menstrual blood, and the menstrual blood will collect there. So what you will get is increasing dysmenorrhea, okay? Now, out here is a condition which is a perforate hemivagina. Now, this is even more difficult to diagnose because, again, here you will get your hematocolpos and hematometra where there is complete obstruction. But if there is a small opening, the blood will be let out, but it will always be intermittent, and there will always be a collection of blood. So these patients will present with intermittent bleeding and sometimes malodorous discharge because there's all blood that is collected there. And you can appreciate clearly that this will pose a hindrance to conception, and especially by altering the microbiome in the vagina. So here we are. You can see distinctly that one side has got blood in it. Here one side has got blood, and the other side won't have blood. And this does not need hemihysterectomy usually. Okay, so because the obstruction is lower down, and this is something we do need to ascertain and remove the vaginal obstruction. So just to go back here. So we approach vaginally and we just remove the vaginal obstruction. It is very important that it is not mistaken for a cyst or an endometrioma, because that has happened. So what are the pregnancy outcomes after the removal of obstructed hemivagina? Now, there's this term called OVERA, which is obstructed hemivagina and ipsilateral renal agenesis. They often coexist together. Remember what we said about the Müllerian and Wolffian ducts? So when there is an issue with one side, you may find that the kidney on that side is missing or dysmorphic. Okay, so overall, pregnancy outcomes. Now, evidence on outcome of pregnancies in Mullerian abnormalities is actually not plentiful, because every center will just encounter a handful, and it is difficult to get a handle on what its true impact is. But it is to say that infertility or pregnancy outcomes. So here it is just a case series, as you can see, but there have been, there are term pregnancies, the risk of preterm pregnancies, again, because of the unicornate or the didelphys nature of the differences. So these risks will increase, okay? And needless to say, the possibility of cesarean section deliveries is going to be quite high. Now, in bicornuate uterus, so what you will get is the lower part of the uterine cavity will be one, whereas the upper part will have the two horns. Now, within that, there will be some differences. So some of them will not cause any problems. But if you are, deciding to put a Mirena in or, anything like that, we will have to recognize that the shape of the uterine cavity will be different, and they may need, say, two Mirenas. Likewise with didelphys. But there are bicornuate uteruses where the connection to the lower part of the uterine cavity is quite small, and this will often present as obstruction on that side. Okay, and as I said before, this needs to be differentiated from uterine septum, and we absolutely must establish whether there is a convex or concave contour of the fundus. And this can be done with MRI or indeed your 3D scan. And as I said before, most of them will not be infertile, but again, malpresentation will be more common. Can we just establish that arcuate uterus simply, arcuate uterus is not an abnormality. We do not need to go and correct it. But yes, with uterine septum, again, it can be subseptate, it can be a complete septum right down to here, it can have two cervices, it can have complete duplication again, just like didelphys, or it can have obstruction. So therefore, we need to completely establish what other congenital malformations exist when we encounter any Mullerian abnormalities, so that we, number one, correlate with the symptoms, and number two, decide on the management plan. So, as I said before, for septum, there is no consensus about whether to operate or not. And if you are just finding septums coincidentally, then there is absolutely no indication to perform any surgery, unless, of course, there was an obstruction. Okay, so but even if there was an obstruction like this, you just remove the obstruction in the vagina rather than going and operating on the septum. But of course, in this case, the septum here, this will cause obstruction on this end of the uterine horn, and this will need to be removed. Let's come to the transverse septum. So there is a difference between sort of imperforate hymen and the transverse septum. Imperforate hymen is not a Mullerian abnormality, because this is at the lower end of the vagina. It is from the hymen and also very easily treated. They are thin, and the telltale sign is that the hematocolpos will make this bulge out. But when you encounter something like this is not an imperforate hymen, and this is definitely a septum. And the best thing to do here is to wait. We take this patient to theater immediately, relieve the obstruction. For this patient, we initiate menstrual suppression whilst we work out the full details of the nature of the obstruction, such as where is it? Is it low? Is it mid? Is it high? How thick is the septum? Okay. And just like in hemivagina, where you may have a perforate septum, sometimes transverse septums may have a tiny opening that is allowing the menstrual blood to come out, and they will also reveal themselves with intermittent bleeding or discharge. Once the septum is removed, they will not usually have any difficulty in conception. However, it is important that we do either suppress as soon as we know and treat, so again, as to reduce the risk of endometriosis and adenomyosis. So we use MRI. It is not essential to use MRI. 3D scan is good, but because they also have renal and skeletal abnormalities, sometimes we find that with one test, we can map out the whole pelvis, any vertebral issues, etc., etc. Okay, so here we note where the obstruction is and how far from the introitus the site of obstruction is. Here you can see it is lower down. That means easily accessed. And if it's higher up, it can be more difficult and the risk of restenosis can be high. In both, we teach them how to do vaginal self-dilation so that once the surgery is done, they can self-dilate to reduce the risk of stenosis. Okay. So risks to fertility from obstruction. I'd mentioned endometriosis several times, but the other risk is that of infection and adhesion. Now, when you meet with the obstruction, and if it is a complete obstruction, then they don't have any risk of infection at that time because you have not breached their defenses. But once surgery is done, that defense is breached and we increase their risk of infection and adhesion. Now, it is therefore very important to do the surgery once and not just drain an obstruction, because if we drain, it will close over very quickly and it will then, that old blood and the contained blood from our next menstruation, etc., will actually increase the risk now of infection. And indeed, we have encountered that. So it is very important to define and perform only one surgery and keep the opening patent. So with hematometra, hematocolpos, that pressure will also lead to sometimes the hematosalpinges, and that can affect fallopian tubes. Again, we find that if we are able to treat it quickly, then the sequelae of these conditions, the occurrence is low, but if delayed or incompletely performed, these risks will be higher. Our colleague Jayaprakasan had and his colleagues had performed or done this scientific impact paper looking at the outcomes of congenital uterine anomalies. There is a more recent 2025 update, but that was more on the definition. But in terms of actually the outcomes, what we find is that it is septate uterus, okay, subseptate, that has the higher impact on pregnancy outcomes, whereas the others, have lower outcomes. And I think this is quite valuable to know so that we can counsel our patients appropriately. And here is a risk or list of the pregnancy complications that we may encounter or may be associated, and therefore they can be monitored for it. So once we have diagnosed and treated, we inform them that they need consultant-led care and an evaluation, such as a growth scan or, looking out for preterm labor. So I want to just spend a little bit of time on anorectal malformations, of which cloacal exstrophy is the most common. Now, this is obviously, an extreme situation, but many of these conditions are actually associated with Mullerian anomalies as well, and uterus didelphys is the most common. But crucially, what these patients may have is bowel vaginoplasty, because their vaginas, as a result of having cloacal exstrophy, the vagina is not formed, and they have bowel vaginoplasty and other colorectal procedures and multiple procedures. So what this increases is the risk of pelvic adhesions, number one. And of course, with bowel vaginoplasty, there can be a discharge, and also the bowel, the vaginal microbiome is different now because of bowel vaginoplasty. They can conceive, but the possibility of natural conception in cloacal exstrophy is actually quite low. But if they do miss periods, we should advise them to have blood tests, because urine pregnancy test in bowel vaginoplasty, because you get the bowel proteins, will give a false positive result. And that's very important. There are only very few pregnancies reported So here we have, one study reporting 24 pregnancies in 16 patients. And as you can see, ectopics, miscarriage risks, etc., are quite high, and preterm delivery. So we send these patients for pre-pregnancy counseling whenever we see them, and also they remain in our care, because of having vaginoplasties, they may need some dilation, or they may have difficulty having cervical smears, so we need to keep them under our care. But alongside the difficulties in the pelvis, there are other issues as well, such as renal issues, congenital cardiac problems, tethered cord syndrome. So we've got to be extremely careful if we encounter patients with cloacal exstrophy. Then comes bladder exstrophy, who will also sometimes have similar or similarities with cloacal exstrophy, but usually they are quite fertile, and the type of surgery they have is not as extensive, and they are more likely to be fertile and conceive naturally than cloacal exstrophies. So if you get bladder exstrophy, it's good prognosis. If you get cloacal, it's poorer prognosis. So just to say, heavy menstrual bleeding, we think uterus didelphys or bicornuate uterus, because the surface area from which they will bleed is higher. Dysmenorrhea when there is obstruction or non-communicating horns. Amenorrhea if there is Mullerian agenesis or complete obstruction of periods, or indeed any hypoestrogenic condition, which we need to rule out. Pelvic pain or chronic pelvic pain may be associated with obstruction of menstruation, cloacal and bladder exstrophies because of adhesions. Intermenstrual bleeding when there is perforate obstruction, or if it incompletely addressed. Intermittent discharge, again, think perforated septums, and urinary retention if they present with urinary retention and pain. And again, this might be due to hematocolpos and hematometra. Very briefly about management, and if there is a part 2, I can deal with management in more detail. So we have to define the condition and then work out the implications of that condition. We should be treating the obstructive symptoms and conditions, and but if we need a bit of time whilst we're working things out, immediately initiate menstrual suppression in the form of, medroxyprogesterone acetate continuously, or noreltestrone. Do not give GnRH, because if you're going to operate, you want your tissue to be nicely estrogenized. But if you're going to give GnRH, you may get poorer healing. Always MDT, get your, if you are operating with a urology colleague, get them in. Or if you're operating on your own, but you want to be defining the condition very well, so form a relationship with the radiologist. And if you do the scans yourself, great. And if somebody else is doing them for you, then form that multidisciplinary team. Please also remember, post-op care is extremely important, and this is often in the form of vaginal dilation. So aim for one surgery only, be wary of stenosis, infection, and sepsis. So this is just a snapshot of all the obstructions that came to us and how they came. Many of them have already had treatments, such as, or some sort of assessments. EUA hysteroscopy, they're actually not required, because a good 3D scan or a good MRI is enough. And by just, you just see, so suppose it's obstructed hemivagina. You will only see one cervix. You're not going to detect your hemivagina by doing a hysteroscopy. Aspiration is discouraged. Salpingectomy should not be performed, because this hematosalpinx will hopefully drain whilst you drain the obstruction. And some of them have had infections because of incomplete drainage. So to conclude, most Mullerian diversities will not have fertility implications, but it's the obstructive ones that we need to be wary of. And in didelphys and bicornuate uterus, no surgical intervention is required unless there is obstruction. In uterine septum, perhaps it's reasonable to do if there is miscarriage or infertility or previous history of poor obstetric outcome, like abruption. We do not diagnose Mullerian agenesis without endocrinology. If we detect a unicornuate uterus, please look for the other horn. Surgical pause. Let's not be trigger happy or scalpel happy. Use menstrual suppression whilst defining anatomy. And timely treatment of obstruction is associated with good prognosis. But of course, overall, the data out there is quite scarce, and it is here that we can, in forums like this, because we'll all have few cases where we can join hands and look at reproductive outcomes. Thank you very much.
Thank you very much, Effia, for a wonderful talk. Definitely at the next webinar, I would like you to talk about the management of these ones, and thank you for volunteering for that. We've got some time for some questions. Let me start off with a question. First thing, it's not a question, it's a comment. Thank you for clarifying that the traditional understanding has always been uterine anomalies cause infertility or increase the risk of infertility. Thank you for clarifying that it doesn't increase the risk of infertility in most of these cases. So one of the questions I want to ask is, you mentioned about looking for the other horn in unicornuate uterus. What would you do if an MRI says there is no there is no other horn?
That's fine, because there may not be any. That means the resorption of that rudimentary horn has been complete. Okay, so if your MRI now, pattern recognition. So I think we are in a very advantageous place because the radiologist we work with, Professor Margaret Hall Craggs, has got years, 30 years of experience. So, her mind knows and therefore her eyes see.
Yeah.
So it's very important that you actually direct your radiologist, please look, because they may report, and we are not very used to seeing, MRIs or working out the differences in MRIs ourselves. I would say spending, if we are doing this kind of thing, spend more time with the radiologist so that we also have some, information and understanding of what things look like. But absolutely, there may not be one. Okay, it's not always, but do look for one, because this is where sometimes, we have fallen short, where it's because it was separate. If it's together in your scan, you will find, like that image I showed. If they are fused, so you have your unicornuate and your rudimentary is stuck, yes, you will see them in your scan. But they may be away. They may be very lateral. And then you may not see that in your scan, and it may be quite high up. And that's when, if you do an MRI, say, please look, there may be a rudimentary horn. Now, if a rudimentary horn has no endometrial differentiation, that means there is nowhere that it can get pregnant. However, it's often attached to a fallopian tube, so you can get an ectopic in the fallopian tube. And definitely we have had a few of these where an ectopic has occurred, either in that fallopian tube, which is attached to the rudimentary horn, or within the horn itself.
Thank you. And the second question is, you mentioned about Mirena, use of Mirena. Again, second thing, traditionally people think that Mirena cannot be used. Thank you for clarifying Mirena can be used. Would you do hysteroscopy in all these patients before you insert the Mirena, look at the cavity yourself and make a decision?
No, I would do it under ultrasound guidance. In fact, I put all Mirenas, or we put all Mirenas under ultrasound guidance because it's there. We can do ultrasound. Why would I put blindly when I can see where? So we place it. You can use Kylina. So, but of course, because there are two, you've got to put two horns.
There's a question from Gulam Bahadur. What is the best location for embryo transfer for embryo implantation in IVF treatment?
Great question. So if you have two equal sized uterine horns, then you can choose. There's no, best. But if it was ovira and they need IVF, that is obstructed hemivagina, now that side has had some insult. So we use the side that was unobstructed. Okay, so there has never been. Also because, your access, because you have done surgery for the obstructed hemivagina, your access may be difficult. If there was a miscarriage, you may not be the one performing the ERPC. So, you want it to be placed on the side where there was no obstruction in the past.
Okay. Thank you, Effia. There are a few more questions, but because of the time, I think we will move forward. Over to you, Raj, please.
Thank you, Harish. It's a real pleasure for me to be introducing our second speaker of the day. Dr. Rekha Pillai is a colleague of ours from Newcastle. She's a consultant gynecologist and subspecialist in reproductive medicine and surgery. Rekha trained initially in Trivandrum and became a consultant in Newcastle about 4 years ago. She's also the clinical lead for a very unique service that Newcastle provides. She's the clinical lead for the mitochondrial assisted reproduction service. She has a very significant research record. She holds a PhD from the University of Leicester, which was in relation to prediction of miscarriage. So amongst other things, she's an expert in early pregnancy complications, as well as, of course, subfertility. She's well known for her expertise on endocrine conditions, 3D ultrasound, polycystic ovary syndrome, and recurrent miscarriage. It's my great pleasure to ask Rekha to talk to us now.
Thank you, Harish, for the kind introduction. I'll start with showing a video.
The United Kingdom is said to become the first country in the world to introduce legislation allowing the creation of human embryos from the DNA of 3 people.
This is a bold step for Parliament to take, but it is a considered and informed step.
The first babies with 3 genetic parents could be born in Britain as soon as next year. It offers hope to families affected by a wide range of diseases caused by faulty genes passed from mother to child.
Describing mitochondrial donation as producing GM babies, or indeed 3-parent babies, are phrases that are wildly misleading.
It's not fair that if there's a scientific technique out there that could resolve this happening and stop this happening in the future, that we're not using it.
We're sitting there with a technique that could potentially prevent the transmission of these diseases.
Mitochondrial disease is an inherited disorder that affects around 1 in every 6,000 babies.
Could help about 150 couples each year who are at risk of passing on certain genetic diseases.
It's aimed at stopping infants from being born with inherited diseases. The new method would take genetic material from a mother, a father, and from a donor woman with the aim of preventing deadly diseases being passed on to the child. It would just be incredible. It is like a light at the end of the tunnel for them.
Children would also inherit the disease unless MPs vote to allow a controversial technique to change the genetic material she passes on.
Mitochondrial disease is just horrific. The way that it affects children, and it shortens lives, and the suffering that children and adults have to go through.
I think this is an important advancement in medicine to allow women to have healthy children.
I think we have to be really clear that there is currently no cure and no treatment for mitochondrial disorders. It's debilitating, it's cruel, and families and parents have to watch their children die.
The eyes to the right, 382. The nose to the left, 128.
So that was the campaigning video we had when we started the program. Now I'll go to my actual talk. Hope you all can see the talk presentation.
Yes, we can.
Thank you. So it's a very niche topic, as you have heard. So I thought I'll start with some basics about mitochondria. So mitochondria is the powerhouse of cell. We all know about that. And it is a double membrane organelle, and it's there. There are thousands of copies of these mitochondria within each cell. They are very susceptible to mutation. They are 10 to 20 times more susceptible than nuclear DNA to have mutation in it. And about 1,100 genes code for mitochondria. Majority of them sits within the nucleus, and only 37 of these genes sits within the mitochondria. And they mostly code for proteins, tRNA, and ribosomal RNA. So the main function of mitochondria is to produce energy for the cell. So it creates ATP through oxidative phosphorylation. I'm sure you all know about it. It's just back to basics. And it also plays a role in apoptosis, calcium homeostasis, and formation of iron-sulfur clusters. So one peculiar thing about mitochondria is it is purely maternally inherited, unlike nuclear DNA. So whenever fertilization happens, the mitochondria that comes through the sperm goes through a programmed degeneration, and the resultant embryo is only left with maternal mitochondria. So whenever there is a mutation to the mitochondrial DNA, it causes mitochondrial dysfunction and it disrupts the energy generation of the cell, and that is how the symptoms manifest. The mutations are have some peculiar features. And one of the reasons is mitochondria replicates different to cell cycle. So what it means that within a same person, each individual cells can have various different mutation loads. Similarly, different tissues has different mutation loads. So if we test the urine of the person, it will have a mutation load very different from the blood and very different from the buccal sample. These are the main three tissues we normally test when we test for mitochondrial mutation. And also, the mutation varies significantly within family members. So, so mother can have a different mutation to the children or to her mom. And these mutations sometimes can happen de novo, all of a sudden, in an individual because of oxidative stress. And they can then clone and expand. And also, the common mutations we see are point mutation or large-scale deletions. So these are the terms I'm going to use throughout the talk. So homoplasmic wild type means all the mitochondria within the cell are normal and healthy without any mutation. Heteroplasmic means the mitochondria, there are some mutated mitochondria and some healthy mitochondria. And homoplasmic mutated means when all the mitochondria within the cell are affected and mutated. So what is the prevalence of this condition? It's quite underreported within the society. More and more awareness is developing. However, within literature, we notice it's present within UK population. It's about 1 in 8,000 women and 1 in 250 live birth. And of that, about 1 in 1,000 women are affected. What is the incidence in South Asian population? We have a link with Hyderabad, and there is a large mitochondrial center in Hyderabad. But when I looked into the literature, this is a systematic review reported from India in 2022. And what it says is that there is significant underreporting and underdiagnosis. There is paucity of data. So they couldn't come to any solid conclusions. But by extrapolating prevalence from other literature, it's estimated that it's affecting about 10 to 15 individual per 1,000 in the population. It is a multi-organ disease having both neurological and non-neurological manifestation. The common symptoms we normally see are blindness, deafness, myopathies, cardiomyopathies. People can present with both renal or pulmonary failure, stroke-like episode like symptoms. So these are some of the common manifestations, but there is a wide range of them. And you might be familiar with some of these terms, which are some of the common syndromes patients present to us with, such as Lone, MELAS, MERV, MID, and NARP, and so on. So, and there are some rare mutations as well. As I explained, it has a very significant reproductive consequence because it's unpredictable how it is going to be in your child. So this is a typical example. This mom who has got mild symptoms and living a reasonably healthy life has only got 38% mutation. Then sadly had a boy who had 78% mutation and passed away at the age of 7. And then she went on to have a girl child with no mutation whatsoever and is completely healthy. So that is a variation we see within each family members, and that's what's making it very difficult to predict. Is there any treatment? There are no definitive treatment so far, other than some symptomatic treatment. So there is more research needed in this area. And probably that is where the role of prevention comes. Can we just completely avoid developing this condition in the new generations? And that's where we discuss the fertility options. Yeah, of course, there is a choice for not to have children You can go for adoption or fostering, or you can go for egg donation, but the child won't be genetically related to you. But the options to have genetically related child are either pre-implantation genetic testing for mitochondrial mutation or mitochondrial donation, which I'm going to talk about next. So PGT mito, or pre-implantation genetic testing for mitochondrial mutation, is just similar to any other PGT. And the steps involved are ovarian stimulation, and we collect the eggs from the woman and do ICSI. ICSI is quite important in order to avoid any extraneous sperm causing contamination when we do genetic analysis. And we allow the embryo to develop until day 3. And this is a picture of a single cell being biopsied from a day 3 embryo, and we send it for analysis. And we let the embryo grow. And by day 5, we get the results back. And then we'll have a multidisciplinary meeting where we have mitochondrial expert, myself, embryologist, and the patient sit together and decide and pick up an embryo which has got lowest load and is of a good quality, and we transfer it back to the patient. So what it means to the patient, remember, these are all patient otherwise without any fertility issues. So as long as we have a good embryo to transfer, their chance of having a pregnancy is quite high. As I said, we need ICSI to avoid cross-contamination from sperm while doing the analysis. It's mainly a risk reduction strategy. It's not a risk elimination strategy. And there is no guarantee that we will have an embryo to transfer at the end. It might be because we don't have a low load embryo to transfer, or there is no good quality embryo to transfer. So therefore, we always, because as I said, this is a risk elimination. There is no 100% guaranteed completely reduction strategy. It doesn't completely eliminate. So we always offer the patient prenatal diagnosis if they wish to choose. But from my experience, patients hardly go for that after going through so much to reach there and have a pregnancy. They hardly take prenatal diagnosis. So as there is a wide variation we see within the family and also between embryos as well. This is our data. And you can see patient 1 has got all the embryos with mutation clustered together. However, you can see patient 4 has a big wide range in the mutation load, with some of the embryos has nearly 100% mutation, and some of the embryos has got mutation as low as 10%. And there is a way, and we also notice there is an association with which mutation patient has got. And it's quite, we see some mutation specific variation as well. So how do we decide which embryo to choose? And we roughly go by this, where we look at the mutation load. If there is no mutation whatsoever, then that is the patient has no risk of, the child has no risk of developing the condition. If the mutation level is low, which is less than 30%, is kind of the rough cutoff we use, and their lifetime risk of developing the condition is extremely low. So we kind of go with a rough cutoff of 30%, although it is a bit variable depending on other factors, which I'll discuss. Intermediate level mutation is when it is between 31 and 70%, and the risk in this situation increases as the level of mutation goes up. If the mutation load is over 70%, the risk of having the condition is extremely high. As I said, this is not just a black and white thing that we follow. There are other factors we take into consideration, such as the kind of mutation and how it was in their family so far. And sometimes the mutation is so rare that we don't have any previous data to back up us with making the decision. So in those cases, sometimes we can get some old case report, and we take that to help us to make the decision. And that is why when we run this clinic, we always have a mitochondrial expert sitting with us who advises on us how this mutation is going to behave. But PGT is not suitable for everyone, especially if it's homoplasmic. That means all the mitochondria is affected. Then you are not going to get an embryo with a low load, because all the embryos will be also completely fully affected by will have fully affected mitochondria. And also, if you have already done a previous PGT cycle and we didn't get any low load embryo, then PGT is not a suitable option for future cycles. Patient choice, though we say that in UK, HFEA has strict regulation that we can only offer mitochondrial donation if PGT is not an option. So first we have to prove that we are not going to get a low load embryo by PGT before we can put an application for mitochondrial donation. So though we are the only center in the whole world where it is licensed to do mitochondrial donation, there are other centers that do PGT. And this is a study from the French group. And they recently published their PGT data, and they published data from 19 women who has gone through pre-implantation genetic testing for mitochondrial mutation. And they had 17 women who went on to they had 16 women who went on to had embryo transfer, and they had total of 29 embryo transfer for these 16 women. And they had 5 clinical pregnancies and 3 live births, which gave them a live birth rate of 16.7% per embryo transfer. Our results are much higher, far much higher than this, which hopefully will get soon published. So now I'll talk about PNT or mitochondrial donation. The technique we use is called pronuclear transfer or PNT. It's in 2010, our team first demonstrated that pronuclear transfer is possible in human embryos. And subsequently, they started the campaigning for clinical application of pronuclear transfer to treat mitochondrial donation. The campaign has nearly gone for 10 years, as I have shown you in the initial video. And I'll talk a little bit of about pronuclear transfer and what it entails. So it starts with fertilization of a donor egg and a affected patient's egg with partner sperm. And then we create, so this is usually done, the collection is usually done in the morning. And by afternoon, we do the XC. And normally the pronucleus develop in 8 to 12 hours time, which will be like early 8 o'clock in the morning. Our principal and embryologist who does is Louise Hislop. She will be there in the department through midnight, through early hours, waiting for this pronucleus to form. And when it is formed, she takes both the pronucleus out, both from the affected woman as well as from the donor. And she put the pronucleus from the affected woman and her partner into the enucleated cytoblast of the donor and recreate the embryo. So that's what it involves. And these are some pictures of pronuclear transfer, where in the first set, the pictures are of removing the pronucleus out of the fertilized egg. And in the second picture, we are putting the pronucleus back into the enucleated cytoblast. So these are some more pictures of taking the pronucleus out. And these are pictures of embryos being developed after reconstituting the enucleated donor cytoblast with the pronucleus from mom and the dad, and developing a blastocyst. This is a video, hopefully you can all see, where a laser hole is made on the zona, and a pipette is going into the cytoplasm and then taking the pronucleus, gently sucking the pronucleus into the pipette and coming out. The other pronucleus is still inside. And in the other video, this is the enucleated cytoblast of the donor. And there's already a hole through which the pipette is going in and putting the pronucleus back into the cytoplasm of the donor egg. So what are the benefits of this technique? The main benefit is the child born through this technique will be genetically related to the parents without transmitting the mutated mitochondrial DNA. So there are some questions raised while this technique was being developed, because we are doing a lot of technical handling of the embryo. Can it cause aneuploidies? Or can it cause any other side effects because of this, all these technicalities involved? can it cause a potential incompatibility between the nuclear DNA and the donor mitochondrial DNA, because its donor is alien to the nuclear DNA. So normally there is a big interaction between the mitochondrial DNA and nuclear DNA. None of this has been proven so far, and none of this has been noticed so far in the children born through treatment with us. But one of the other potential risks is a risk of carryover. Carryover, this has been demonstrated in the mouse embryos in the preclinical studies within our team. And what carryover means is that when we take the pronucleus out, a bit of the cytoplasm also comes along with it. And when we put that back into the enucleated cytoplast of the donor, these mitochondria along with within the cytoplasm, which is already mutated, can go along with the pronucleus back into the donor egg cytoplast, and then it can multiply and cause the mutation back. So that is a risk of carryover, and there is a less than 2% risk of this happening. And there is risk of reversion, and risk of reversion means when we have taken a pronucleus out without any cytoplasm whatsoever from the mother, and we put the pronucleus back into the donor, and when the embryo subsequently develop, we have noticed that some of the original mutated mitochondria from the mother keeps coming back within the developing embryo. We don't know why this happens. Is it because of the nuclear genome interaction? Still to find out. However, this has been noticed. And this study was published from the Spanish group. They did mitochondrial spindle transfer not for mitochondrial mutation avoidance, but to improve the fertility outcome in women who had multiple IVF failures. And what they have noticed is one of the child had the original mitochondria from the mom in 30 to 40% of the mitochondria in the cells. So that is risk of reversion, which also we are watching for in babies born to us through our treatment. Well, so another technique we can use, as I explained in the previous slide, is mitochondrial spindle transfer. Here, instead of pronucleus, here we transfer the metaphase to spindle. In order for the spindle to see, we need to use a fluorescent dye. And there are concerns whether this dye can affect the embryo development. And also, unlike pronucleus, the mitochondrial spindle is not within a confined cell membrane, which also raises the concerns whether you can have chromosome segregations and aneuploidies. Now, I'll talk about the program quickly. As I have shown earlier, while we are getting the final clearance of the regulatory hurdles in UK, this news leaked out from Mexico that a baby was born through mitochondrial donation program by a group of scientists from America. Went to Mexico to do this in order to escape all the regulations in the US. And this caused some setbacks for the campaign. We were doing with mixed press reactions. And eventually in 2015, we came out of all the hurdles and then got the regulatory approval in 2015 to do the program, donation treatment program in UK. And this was a completely NHS funded program, and all the patients come to Newcastle to have the treatment. And we have a multidisciplinary team involving mitochondrial specialists, fertility specialists, embryologists, nurses, genetic team, and research team. And how it works is the patients get referred to us from all over the country through neurology, genetics, mitochondrial team, and from other fertility specialists. And they go through a MRAC clinic, which is a clinic run by the mitochondrial specialist. They look for, they do a complete medical assessment from a mitochondrial point of view, redo the testing, and then when they have ready to have children, they will send to us, the patient to us in our MART clinic, where we have both fertility specialists and mitochondrial specialists. We undertake all the fertility assessment, and then when they are ready, we offer them treatment. So this is the broad framework we follow. If they are homoplasmic, the mainstay of treatment is pronuclear transfer or mitochondrial donation. Of course, they have the option for egg donation. If they are high heteroplasmy, if we can prove that there is no chance for PGT whatsoever, depending on the type of mutation, then it's mitochondrial donation. or they can go for egg donation. If it's low heteroplasmy, then they should go through PGT because we have high chance of getting a low load embryo. And also they have the option of trying for natural pregnancy and do a prenatal testing plus minus termination of pregnancy if the child is found to have high load of mutation. If the patient is clinically, they all have the option of adoption, fostering, or not having children. But if they are clinically unwell to carry a pregnancy, then we offer surrogacy with one of these treatments, which is most appropriate for them. We have a very holistic approach to our patients. Many of these patients are known to us for a long time through the families, and they come to us from a very young age. So they would have discussions very earlier on in their life about their reproductive options, and we get them ready medically to ensure that fit for pregnancy. And they will have counseling support through and through, before, through, and after treatment, because it's a very it's a procedure which has a huge emotional burden on the patients. And we follow a multidisciplinary team approach to look after them with dedicated nursing care and counselors available, and they are very well looked after through their journey. I'll just briefly go through the PGT pathway. They come through MRAC clinic, then we will have an MDT between the mitochondrial team and ourselves, and then they come to a fertility clinic where they have a fertility assessment. And then when they are being referred for PGT, we will have an MDT with obstetricians, other healthcare professionals, and anesthetists. And then we refer them for PGT, where they will have counseling and consenting. Then they go through the whole process of PGT, and finally embryo transfer. The PNT pathway looks somewhat like this. They come to the MRAC clinic, very much like the PGT, have an MDT between them and ourselves. Then they come to a fertility team, and then they are ready to have treatment. We have to hear the main differences. Every single patient has to go through HFEA for individual license and approval. And HFEA consider each individual application through their scientific committee and external advisors. And finally, if they think that it's appropriate, they give us approval to do the PNT for each patient. And then they will see them back. They go through MDT with the whole range of team, and they have counseling, consent. Initially, we start freezing patient's egg because it's quite difficult to coordinate the treatment cycle of both the donor and the patient. And then we get the donor ready, and then stimulate the donor, and simultaneously get the patient ready to receive the embryo. And once we collect the eggs from the donor, we thaw the patient's eggs, do PNT, and develop the embryo and transfer the embryo. And the babies are followed up through Wellcome Trust funded study. And we take first initial sample from their cord blood and the Guthrie test. Guthrie test is a neonatal test is given to all patients, offered to all children born in UK to look for a wide range of conditions. And we use the same test, blood from the same test, to assess for mitochondrial mutation as well. This is to avoid any extra interventions to the babies born. And they are all followed up through their routine health check to avoid seeing them as an experimental object. So challenges is often the long wait to start treatment due to individual HFEA application, multiple healthcare professionals needs coordinating, and also it's fully funded. However, the patients are traveling to us from far and wide, which means that travel can be quite expensive, accommodation is expensive, and patient can often struggle with that. They will all get this money refunded through the Lilly Foundation, which is a charity supporting mitochondrial treatment. And also there is difficulty with availability of donors. So this is the news leaked out about our first baby born through the donation program, though our publication is almost ready to come out now. And this is the treatment we have done so far with about 36 PNTs. And now it's more than that. This is data from September. We have done more than 39 PGTs now. Thank you so much for patiently listening. And this is our team, both our present and past team. Some of them have retired, without whom and without the patients and the charities, this would not have been possible. So thank you so much to all of them for making this possible. And thank you for kindly listening to me.
Thank you so much, Rekha. You thank us for listening to you, but really we should thank you. This has been such an inspiring, such an amazing talk to listen to. Dr. Ghulam Bahadur, I think, says it for all of us in the chat when he says that this is a really complex procedures, a really complex pathway, complex patients. You're coordinating so many different aspects of care, coordinating different teams of clinicians. We all start life as fertility specialists, but you've gone way beyond here. This is really, really creditable. And it's an amazing work done by yourself, your entire team. And I think your predecessors as well in Newcastle all deserve a lot of congratulations for this. So
Thank you, Raj.
there are some really nice practical questions which have been asked. Dr. Ishita Mitra and Pravina Pai both want to ask, how do you determine homoplasmy, heteroplasmy?
So by doing the genetic test, so we sent three samples. Usually, it's urine, buccal, and blood, and then it will tell whether all the 100% mitochondria is affected, or 50% or 25%. So what percentage of mitochondria affected? So genetic results come back as homoplasmic for 3225. Mutation, something like that, or they will say it is heteroplasmic with 40% in urine, 30% in blood, or 60% buccal sample.
Fantastic. And then there's another practical question. Presumably having some kind of time-lapse imaging is essential because you need to identify the PNs.
Yes, we have time-lapse for this.
Okay. We've very little time because the talks have been so interesting and detailed. But can I just ask your view on, do you think the future is going to be continuing with pronuclear transfer, or do you think spindle transfer will take the place, or do you think both will be on an equal footing?
So far, we are getting very good results with pronuclear transfer. So there is no incentive for us to move to spindle transfer. The only reason we might think of, we are starting to do some embryo studies on spindle transfer. Sorry, if we are on some research X, we are starting to do some studies on it, only because in case if we get a case of reversion in the reversion, then we are trying to see by doing spindle transfer whether we can reduce it. But so far, there is no incentive for us to move away from pronuclear transfer.
Thank you. And can
As I said, it has its own difficulties with spindle transfer because we have to use a dye, and we think whether that dye can affect embryo development.
Sure.
And there can be risk of chromosome segregation. So the manipulation has to be really carefully. It has to be carefully manipulated so that the segregation of the spindles won't happen.
Thank you. And can I just confirm that the treatments you provide are NHS funded?
They're all 100%. So the mitochondrial donation is purely only available for patients in UK, and it is 100% NHS funded. For PGT, which is a chunk of our treatment, is PGT, and all the UK patients, it is NHS funded, but we provide it for international patients as private patients.
Thank you very much. Rekha, once again, let me thank you for an amazing presentation. It was a real pleasure. Thank you. And back to you, Harish.
Thank you.
Thank you, everyone.
And thank you very much, Rekha. That was really a wonderful presentation. And I would like to thank Effia. Despite not being well, she's stayed back to answer the questions that were in the chat box. Thank you so much, Effia, for that. Next speaker is Mr. Himanshu Borase. He'll be talking to us on the role of technology and innovations in women's health, which is kind of, thing that we all have started using. Himanshu is going to give us more information on that. Himanshu is a gynecologist and is an IVF specialist. He trained initially in Mumbai, then in Bristol, Oxford, and Aberdeen. Now he's a consultant in Bart's Hospital in London. He has special interests on polycystic ovary syndromes, ultrasound scanning, training a new generation of reproductive medicine specialists. And apart from that, he's a runner. He's one of the doctors who has done ultrathon in the UK. He's a keen photographer hiker and an avid Urdu poetry lover. Over to you, Himanshu.
Thank you very much. Thank you for giving me an opportunity to speak today. And thank you very much everyone who is expending India-Pak match. So if you want to stop me to celebrate some wicket or something, just raise your hands and I'll wait for a second. So today we are talking about technologies and innovations in women's health. So basically, any technology-driven solutions for women's health are sort of segregated under a term called femtech, and it's an upcoming field and sort of taking over our patient care quite nicely at the moment. So the current femtech solutions, they are focusing on reproductive health, pregnancy as well as postnatal care, menstrual health, menopausal support, sexual health, as well as general well-being. Although the tech available is still quite sort of a fragmented. And why does it matter to all of us at this moment? It's because historically women have been underserved in not just health tech, but overall research paradigm as well as decision making. Because if you remember that even in previous times, women were not part of the clinical trials, and they are being treated with the medications which are trialed mainly on men. As well as in the families, women are making 80% of the decisions for family, but they are still struggling to make decisions for themselves or seeking help. The femtech market is projected to reach 100 billion by 2029, or potentially with inflation, it might go even more. And the main use of these technologies is that to bridge the gaps in women's healthcare. And it provides personalized, accessible, and stigma-free options for women. So there are plenty of apps available across the globe at the moment. You might be familiar with quite a few of them. So Clue and Flow are the most commonly used ones. There's another Eve. They are focusing mainly on menstrual cycle, symptoms during menstrual cycle and everything. Eva, Glow, they are talking about fertility windows, especially for women who are trying to conceive. Geneve is the app which supports women struggling with menopause. LV is the app which works with pelvic floor health and sexual health. Now, the femtech in India, it's quite a new thing, although there is an awareness growing between women about their own health issues, and that's why it really matters. There is an increasing use of smartphone as well as internet penetration. Means even in the remotest areas in India, we are getting full 5G coverage. The smartphone usage shot up quite amazingly. There is a rising demand for various health-related apps. And there are some Indian startups like Niramai, Maya, Veera, they are working on it. But even then, it is still quite sort of an unexplored area, especially in India and some other countries, or even in the UK, it's not sort of a well-versed beyond certain apps. So the current femtech trends and innovations, which is AI, which is coming now, whether we like it or not, and it is supposed to apparently revolutionize the whole thing. And it has already started. Like there are 5 hospitals in US where there are no radiology consultants because AI is reporting. And I think last week, one of my registrar told me that in our trust, they outsource the radiology imaging, and the report was actually made by an AI robot. So it is coming, and it is going to help us with diagnostics as well as develop a personalized care. The wearable health technology is already coming. We are all using smart watches, which are measuring your heart rates and trends in your heart rate while you're walking, while you're asleep. There are some watches which are checking your sleep pattern and everything. We are all using the diabetic sugar monitors that helps you to control or keep an eye on your blood sugar levels and monitor your medication. The work is going on digital contraception as telehealth services for women. And the blockchains are coming just like Bitcoins for secure health records. So what are the benefits of this fintech? Mainly is the accessibility, because when people are living in far distances, or even they are in cities or well-populated areas, the access can be quite tricky. So this allows them to have good access to healthcare information, as well as it allows you to personalize your care, because it's collecting your data, analyzing it, and giving you some warning signs. It also helps to educate and increase awareness about various health issues. The current status of patient education is quite dismal, and this allows them to grow better awareness of their own health issues. Obviously, with TikTok and Instagram, there is an abundance of health-related information, but it's unfortunately 95% it's going to be by unqualified people, and it cannot be trusted. It will also allow women to empower themselves about their own health. And most importantly, it's a stigma-free approach because it's anonymized as well as confidential for them. The future is coming that there is going to be increased integration with AI and machine learning. So more data we gather, more better analysis we are going to get with it. And that will allow us to design personalized care for each and every of the patients. There is a growth of telemedicine for gynecological care. The more investments is underserved areas like menopause and mental health, because menopause is quite sort of it's a talk of the town at the moment, and lots of information is coming up about using HRT, not using HRTs, and their risks for women's health. But it will also allow us to expand into the rural as well as low-income regions, where access to healthcare is always not possible, or sometimes physically difficult because of the geographical restrictions to these areas. The whole idea of this femtech revolution is to empower women with data-driven health insights, because as the data is collected at a personal level, it allows us to design a personalized approach to their care. It will also improve early detection and prevention of diseases, because as far as what I have observed working in India is we still lack sort of awareness about preventive strategy. So lots of patients will be waiting far too late until they seek help, and by that time it could be too late to have a proper treatment and recovery from it. So this will allow us to design templates where there will be early warning signs, and then a patient can be warned about any particular condition and guided to the specialist in a timely manner. It will also help to reduce the healthcare accessibility gaps, and it will encourage global investment as well as policy changes. The current challenges it is facing is data privacy, because I've spoken to a few of my colleagues in India, and they had used some of the current technologies, and they said that they were not happy with their data security. And that is going to be a big challenge, because once the data starts pouring in India, it's going to be a huge amount of data collection, and keeping it secure is going to be one of the biggest challenges. Obviously, the accessibility, but now we have got internet as well as smartphone use is skyrocketing. So accessibility will be soon sorted. The cultural barriers, because I was just talking with some of my colleagues in India, and they say the same thing, that not everyone is very happy to use these things. And sort of it's now a challenge to allow them to start using it or increase their usability for their own benefit. And obviously, lack of research in these areas sort of puts a dampener on further spread of these technologies. So based on all these things, we designed an app called Nari. We launched it in India on 15th of August, and it is available on Play Store. And it came to the UK in January this year. I'm still figuring it out, the Apple Store configuration, but we will be working on it, and it will be sorted on App Store in next few weeks as well. Currently, it's focusing on menstrual health and fertility. But the idea is eventually it will cover the whole paradigm from adolescent gynae to menopause, because as you saw that there are plenty of apps available, but they're quite fragmented. They're only covering one part or the other, but not the whole women's health paradigm. And that's what my idea was behind developing this, is even though currently we are focusing on menstrual cycle and fertility, the idea is to cover everything from adolescent gynae to menopause. We will add benign gynecology, urogynecology, gynec cancers, sexual health, mental health, as well as obstetrics, where the patients can register and it gives them insights into menstrual cycle. The way we added AI to it, it really is going to help them, because when someone logs moderate to severe painful cycles consecutively a few times, it will flag up and warn them that this could be sign of endometriosis. Would you like to seek specialist help? If someone is logging irregular cycles, it will flag up suggesting that this could be because of irregular reduced reserve or PCOS, and if they want to seek specialist help. But the other most important thing we are planning to do is we want to promote this diary as mental health diary for both men as well as women. So if somebody is consistently putting anxiety or depression, then there are chatbots incorporated, so they can have a chat with the AI, and the AI will check if they're okay, if they have enough support available, if they would like to seek specialist help, and guide them in the right direction. We also created a secure hospital portal to promote electronic patient records in India as well as other countries where it is still not a norm. And it is cloud-based, so, and not being server-based, that means there is no risk of it crashing or anything. And it is European GDPR compliant, so the data of the patients is going to be secure for hospitals as well as for patients. And this hospital portal will be cloud-based, it's personalized, it's GDPR compliant, it's easy to use, and it's comprehensive. So in the NHS, when we use electronic documentation, we are again using a fragmented approach, that we have to use a separate thingy for blood test, a separate server for images, a separate entity for documentation, and a separate entity for admin work. So we have combined it all. So you got your admin portal, you got images, you got blood results, you got patients documentation, you got your prescriptions all in one place. And because it's cloud-based, it's quite sleek to use. And we are also planning to bring on online consents, as well as a separate portal for IVF clinics to use from an Indian perspective. So for individuals, we want them to explore these femtech solutions to take charge of their own health. For clinicians, those who want to modernize the care, they can start using it. For investors, we are requesting to support the femtech startups and drive this innovation. And for policymakers, we want them to advocate for better funding and research in women's health, because the whole AI paradigm is that more information it gets better at understanding the problem and giving far more personalized solutions. And that's our idea. So currently I am doing a course from Harvard Medical School about AI in healthcare, and we are planning to start use of AI in surgical training as well as training docs and gynae trainees. So at the moment, it is growing rapidly with huge potential to transform women's healthcare. The investment, innovation, and policy support will shape the future, and it's the time now to embrace and support femtech for a healthcare future, because we like it or not, it's already here. And with the help of AI, it's only going to get way, way, way bigger than we can imagine. So we want to make sure that we are in line with the global demand, and we take the steps to help our patients across the globe. Thank you.
Himanshu, thank you very much for a wonderful talk, and many congratulations on the Nari app and the website. We got some time for questions, and I've got a question here from Efia. Efia wants to know if Nari is available in other languages, because this will be hugely beneficial for non-urban women in India who find access to healthcare challenging.
Yeah, but that was the whole idea, because the state of patient education even in the UK is quite dismal. What I'm observing is whatever is available is geared towards fertility, IVF, as if women don't need anything else. But the whole problem is funding, because until now I have sorted everything from my own pocket, and the idea is that to release this MVP, get the use, then get funding. And once we have streamlined all the issues, then develop a multilinguistic profile as well, with all major languages in India, potentially across the globe. And with AI, it won't be that difficult. So yes, definitely that is on the cards. At the moment, funding is a bit of a issue. So if someone has few £100,000 to spare in their drawer, please do give me a call.
Okay. Gulam Bahadur is congratulating you as well as Zuma Gordon, Himanshu. They
Thank
feel
you.
that you are ahead of the AI curve. Gulam has another question, actually. Other factors which could be considered in ethnic differences, which we recognize globally. However, these differences are also prevalent in India.
Yes, definitely. And that's where because that's the idea about getting more and more data, because once patients start using it, we get more data, and the AI analyzes it and actually creates a very personalized approach. And that's why we are promoting this now. Once the Apple Store thing is sorted, then we will go for aggressive marketing. But at the moment, with just mouth publicity, we have reached around 3,000 plus downloads. There is definite interest, and I'm working with some of my colleagues in India about developing an IVF portal from Indian perspective, because ideas and everything, they found it very expensive from Indian standards. Plus, ideas has far too many things which we hardly use. Like, we are all using ideas for last 12 years now, probably, or more, and we use just 5 things. We have never used anything else. So it's like I'm working with my Indian colleagues to design a portal which is for them exactly what they need to do. And once we start getting data, that will allow us to analyze the data in various factors and then figure it out, all the cultural differences in practices, and then sort of try and streamline it for everyone's benefit. But mostly for patients, because in India, the thing is, like, the patient education is quite tricky. Main problem is the time. So we have got enough time. We spend 20-30 minutes, sometimes longer, if the patient needs us. But in India, when they are doing 100 and 150 patients in a clinic, it's impossible. So I also have a YouTube channel where I talk about patient education. I make patient education videos. So they are in English, Marathi, and Hindi. But eventually we will start with the use of AI. We are trying to make them in different languages as well, to sort of bridge this gap, give them some evidence-based information which they can use. And similarly, after speaking with my Indian colleagues, knowing about their time constraint, we are working on a voice memo. So if a clinician doesn't have time in clinic to type the notes, they can just speak and the AI will transcribe it, which will definitely save the time. And I think they will be interested in using it.
Thank you, Himanshu. I wish you all the very best for your future, and ambitions. Now I think, we'll have to close the meeting. We have a few more questions, but I think, in the because of the time, we have to close this. I'll hand over to Raj Mathur to give a vote of thanks, please.
Thank you, Harish. Thank you to all our speakers. You've given us an amazing morning. I don't know what's happening in the cricket, unfortunately, so I can't give you any new information about that. But thank you so much to the audience who've attended, who've given up watching the cricket for this, and that's quite a big sacrifice. So we've had three amazing speakers. We've had Effia, who has given us a masterly overview of a really, really complicated subject, which I think is gradually moving towards more coherence. At least we can all now agree on what to call these anomalies, because I remember arguments about what actually the name of the correct name of the anomaly you're seeing should be. And I'm sure Effia will come back and talk to us about management in detail another time. So that was an amazing talk. Rekha presented a completely fantastic presentation on something that is still so cutting edge, so advanced, and I think the implications of this for the well-being of offspring in the future are going to be stunning, and will work out over the next few decades, and is a very fantastic field to be talking about. Himanshu, what can I say? You are so much ahead of the curve on artificial intelligence and information technology. This is the way of the future. Well, I will withdraw that comment. It is the way of today, and you're riding the crest of this wave. Thank you for introducing it to us today. There's some very important practical things that you're doing, that you're working on. I'm glad to see you're liaising already with colleagues in India, and there are lots of colleagues from India on today's talk. I'm sure they can liaise with you directly, because this is useful for everyone's clinical practice and patient care. So without further ado, I will say thank you once again to all our speakers, my co-hosts, and to all the audience who attended today, and see you all again next time. Bye-bye.
Thank you.